Welcome, my name is Gabriel Elul and I bring you another show of the Synapse, bringing content that matters to the busy medical professionals. With us today, we have Professor Stephen Fava, who will be speaking about the role of new anti-diabetic medications, as well as the efficacy and use of conventional anti-diabetic medications. Welcome, Professor.
Pleasure.
With regards to certain medications like metformin and sulfonylureas, they've been here used for quite some time. What is their role right now in medicine?
Well, let's start with metformin. Metformin, as you say, correctly point out, has been with us for quite some time. And it is actually the first line in all guidelines in the treatment of type 2 diabetes. Obviously, unless contraindicated or not well tolerated. The reason being, one, it's inexpensive, and that is an issue with any medication that we use, that is the expense incurred on the patient or on the National Health Service. And it's also effective. So it's inexpensive and effective and quite safe as regards side effects. In fact, it has no hypoglycemia risk as opposed to many other oral hypoglycemic agents, and is not associated with weight gain. In actual fact, it's associated with some weight loss, about 2 to 3, 4 kilos in most patients. So there are major advantages in the use of metformin. Another reason is then the United Kingdom Prospective Diabetes Study, the UKPDS for short, had shown that in the obese diabetic group, metformin was associated with cardiovascular benefit. So metformin is first line in all type 2 diabetic patients unless contraindicated. And the main contraindications to metformin use are liver failure or chronic kidney disease. The question of lactic acidosis, which is the dreaded side effect of metformin, is actually quite rare. And one of many meta-analyses which have been done recently show that actually it's not associated with increased risk of metformin, of lactic acidosis. So the side effect of lactic acidosis metformin has probably been exaggerated and overestimated. And in actual fact, I have never seen the side effect related to metformin, that is lactic acidosis. The main side effects of metformin are gastrointestinal, that is diarrhea, nausea, and vomiting, which can be inconvenient to the patient but not serious. They can be inconvenient to the extent that they might require withdrawal of metformin. However, it is worth pointing out that if metformin started at a low dose and decreased gradually, then these gastrointestinal side effects are much less, rather than start with a big dose immediately. And also, these side effects tend to decrease with time. So unless they're very severe, the patient should be advised to continue on the medications because probably the side effects will subside with time. If not, obviously, especially if severe, they would need to be withdrawn and placed on something else. As regards sulfonylureas, there's also been with us for quite some time. Sulfonylureas also have the advantage of being effective and of being inexpensive, like metformin. However, they are associated with severe risk of hypoglycemia, especially the long-acting sulfonylureas, which should actually no longer be used. We should go for the short-acting sulfonylureas, which have a much lower risk of hypoglycemia. However, this risk still exists, so the main disadvantage of sulfonylureas is the risk of hypoglycemia.
And many different types of sulfonylureas exist. Some of them are given free by the state, others are acquired commercially. What can you comment about this difference and their clinical use?
As long as it's short-acting sulfonylureas, there are some which are available on the NHS and some which are available in the private market. As long as we go for the short-acting, that is the sulfonylureas we should choose. But I repeat that sulfonylureas even the short-acting are associated with hypoglycemia risk, although the short-acting are obviously less than the long-acting. And it's pertinent to point out that hypoglycemia is much more than an inconvenience to patients. It is inconvenience. It's quite embarrassing if a patient, let's say it's a social event, and he suddenly loses consciousness of hypoglycemia. It can be quite embarrassing to the patient. But it has also been shown that hypoglycemia is associated with acute coronary syndromes, strokes, fits, that's epilepsy, and cardiovascular events, and death. So it's not something to be taken lightly. Hypoglycemia can also predispose to motor vehicle accidents, can predispose to other forms of accidents like accidents in the home. And there's a trial coming from the ACCORD sub-analysis, sub-study of the ACCORD trial, which shows that repeated hypoglycemias are associated with cognitive impairment, that is dementia. And even one episode it was associated with cognitive impairment. The reason being that one hypoglycemic episode probably is a marker for more undetected hypoglycemic episodes. So hypoglycemia is not something to be taken lightly. It is associated with significant morbidity and mortality and reduced quality of life to the patient.
Prof, diabetes is a well-researched disease, and being well-researched, being innovative, the medical field has devised a number of new medications, new classes. Some of them have been used quite recently or further back. One of them is the alpha-glucosidase inhibitors, a particular class. Where would you place these in clinical management, in the importance of clinical management?
Okay. The reason why there's a lot of research into new treatment modalities in type 2 diabetes is because there's a large unmet need. Unmet need because although insulin can be used in all patients who have uncontrolled type 2 diabetes, a lot of patients are afraid or reluctant to start insulin. And most patients would prefer oral treatment, although we should never scare patients off insulin because it's a drug which can be used in all patients in whom control is not adequate. There's also a great unmet need because with traditional treatment of type 2 diabetes, it's a balance between good glycemic control, which we know reduces risks of complication on the one hand, and on the other hand, reducing the risk of hypoglycemia. The tighter we go with glycemic control in an attempt to reduce risks of long-term complications, the greater is the risk of hypoglycemia. So we're in effect walking a tightrope. And it's also been shown that in elderly patients, the greater the glycemic control, the greater is the risk of falls. So even, let's say, hemoglobin A1C of 9, which is not very good optimal control, is associated with more falls than a hemoglobin A1C of, let's say, 11 or 12 in elderly patients. So there's a large unmet need to treat diabetic patients, type 2 diabetic patients with oral treatment, and also with treatment which has no or minimal hypoglycemia risk. Now, the alpha-glucosidase inhibitors are very good drugs in the sense that they inhibit the disaccharidase, which is the enzyme which breaks down disaccharides, and hence these disaccharides are not absorbed because they are not digested. So they are very good postprandial agent, that is, they lower the postprandial blood glucose with no risk of hypoglycemia because they only inhibit the digestion and hence the absorption of complex carbohydrates and disaccharides. Their main side effects, unfortunately, is they have quite severe gastrointestinal side effects, and that is the main reason why they have not picked up so much in their use. There's actually a lot of evidence on the use of alpha-glucosidase inhibitors that they can reduce carotid intima media thickness, which is a surrogate marker of atherosclerosis. So whilst the data is quite good, because they're not associated with weight gain, again, they're associated with weight loss, because they reduce absorption of carbohydrates. They're not associated with hypoglycemia, and they potentially have anti-atherosclerotic effects. Although the data is good, their use, unfortunately, has not picked up, mostly because of these very troublesome gastrointestinal side effects.
On to DPP-4 inhibitors, Prof. So, as we know, they're not funded by the state but privately funded, and maybe the financial reason behind this may be a deterrent for diabetics. However, how useful are they in current management, and can they be used as a monotherapy or later on in combination with insulin? What is the implication of this?
Well, DP4 inhibitors act on the enzyme dipeptidase, which is they break down GLP-1, glucagon-like peptide 1, which is a natural incretin hormone which stimulates the release of insulin by beta cell in a glucose-dependent fashion. So normally after a meal, what happens is that our gut senses food and they release a number of incretin hormones, which include GLP-1, GIP, and oxyntomodulin. And these stimulate the beta cells of the pancreas to secrete insulin in a glucose-dependent fashion. That is, the more glucose, the more insulin is released. If there's no glucose, no insulin is released, or there is low blood glucose, no insulin is released. GLP-1 also inhibits the release of glucagon by alpha cells, again in a glucose-dependent fashion, and delays gastric emptying, thereby inducing satiety, and also causes central appetite suppression. That is at the hypothalamic level. It impinges on the hunger center to reduce hunger. Now, what DP4 inhibitors do is they inhibit the breakdown of natural GLP-1 and hence prolong its half-life. Because GLP-1 stimulates insulin release and inhibits glucagon secretion in a glucose-dependent fashion, they have no hypoglycemia risk. So these are one of the newer agents which have no hypoglycemia risk. Another advantage of DP4 inhibitors is they're not associated with weight gain. They're actually weight neutral. The reason why weight neutral is because they induce some degree of appetite suppression. On the other hand, the fact that they raise insulin, like all other insulin secretagogues, that tends to promote weight gain. So the two effects cancel out and they're weight neutral. So those are the major advantages. That is, they're effective, they have no hypoglycemia risk, and they're weight neutral. They're very well tolerated, very little side effects compared with placebo. Their main disadvantage is their cost, as you rightly pointed out. So actually they can be used at any stage, monotherapy, dual therapy, triple therapy, or even with insulin. They are now licensed for use in all these combinations. However, when to introduce them is really a question of price. Again, most guidelines nowadays, not most, I would say all guidelines, recommend the use of DP4 inhibitors as an option, as a second line after metformin. Now, in which patients would tend to use DP4 inhibitors? In those patients who have recurrent hypoglycemia, that have problems with hypoglycemia, they're overweight or obese, and those who have an increased risk of hypoglycemia. They might not be getting hypoglycemia, because if they do get hypoglycemia, they're at a very increased risk of complications. In that case, we would prefer using an agent which has low or no hypoglycemia risk. Such patients will include those with coronary artery disease, for example, because such patients, if they get hypoglycemia, might get a further acute coronary syndrome. Elderly patients who are very, especially frail elderly patients who have got hypoglycemia, they can injure themselves, have an injury, fracture hip, for example, and then a complication. Patients with known to suffer from epilepsy because hypoglycemia can precipitate further fits. Certain occupations like bus drivers or heavy goods vehicle drivers, because then again, if they get hypoglycemia, that can have major disaster. Even more pilots, for example. You've got a pilot who, if you get hypoglycemia, obviously that can have quite severe consequences.
Exactly. And when describing the role of the DP4 inhibitors, you've elaborated about the breakdown of GLP-1 and the receptors. A particular new drug which is developing and which is gaining ground are those classified as GLP-1 receptor agonists. What can you comment about them?
Okay, so these again use the incretin system. That is the release of natural GLP-1. Now, the DP4 inhibitors, the problem with GLP-1 is first it's a protein because it's a hormone. So, like insulin, cannot be taken orally. And the second problem is got a very short half-life, natural GLP-1. So the only way it can work is by intravenous infusion. So there are two ways which can circumvent this problem. Either give a DP4 inhibitor which will inhibit the breakdown of natural GLP-1, and that can be given oral. Or else give a GLP-1 analog or GLP-1 mimetic or a GLP-1 receptor agonist, where they all mean the same thing, which means they are similar to GLP-1 and they bind the receptor and stimulate this receptor. But with the difference that they are more resistant to degradation by DP4 and therefore have a much longer half-life. So the main advantages of these GLP-1 receptor agonists or GLP-1 receptor mimetics, as I said, is that they are associated with weight loss now, rather not just weight neutral, because they stimulate the receptor much more than the small amount of GLP-1 which increases with the DP4 inhibitors. So it's associated with weight loss, which can vary from a couple of kilos to 20 or even 30 kilograms. So it can be quite substantial. Again, no hypoglycemia risk. The main disadvantages are again the price, so they're expensive medications, and the fact that they're injectables, which a lot of patients tend to dislike. However, they have again a place, especially in those who are obese and those who are massively obese. GLP-1 receptor agonists have a big role to play there.
And on to the last specific medical treatment, long-acting basal insulin has been with us for quite some time now. Mm-hmm. How can you compare their use with conventional insulin? What can you comment about them?
The insulin analogs in general have been formulated to have better pharmacokinetics. So if you use conventional human long-acting insulin, the problem that its levels are not constant. It peaks after a few hours, and then its action starts to drop. So this is a very poor mimicker of natural basal insulin secretion. Normally what happens, we have the beta cells of our pancreas produce insulin at a constant rate, but then when we eat, there's a postprandial surge in insulin secretion to limit postprandial glucose excursions. This is very poorly mimicked by conventional human insulins. So the basal insulins have a better profile in that their effect is more plateau. The main advantages here is they have lower risk of hypoglycemia. Because what happens with the human insulins, since when they peak, there's a greater risk of hypoglycemia, whilst towards the end of the dose, when the next dose is due, their effect tends to wane, and hence at that point there's hyperglycemia, the so-called end-of-dose effect. So the basal insulins, although they're not perfect, because they're not a perfect plateau, are much better in mimicking this basal insulin secretion.
And with regards to what you've just said, now what can you comment about short-acting insulin?
Short-acting insulin analogs, again, have been formulated to mimic more the physiological insulin secretion. So as I said previously, normally there's a basal insulin secretion throughout the 24 hours, and then just after a meal, there's a postprandial increase in insulin secretion to limit postprandial glucose excursions. Now, the traditional human insulin is very slow, although we call it fast-acting, is relatively slow-acting and takes quite a long time to act, and its duration for peak action and also the duration of action. So because it peaks so slowly, we get postprandial hyperglycemia because they don't act quick enough. And because they act for a long time, 4 to 6 hours, then you can get late postprandial hypoglycemia, because what normally happens is the insulin increases immediately, after 2 hours it goes down. Now with the short-acting insulin analogs, they peak more quickly and their duration of action is shorter. So they mimic better the physiological postprandial insulin secretion, and hence they are associated less early postprandial hyperglycemia and less late postprandial hyperglycememia. Now they can be in type 1 diabetes, they would need to be used with the main meals in this called basal bolus insulin regime. With type 2, you can use the basal insulin and the short-acting insulin analog with the main meal, the so-called basal plus regime. And then the other meals can be covered with an oral agent.
We've spoken elaborately about the medical treatment for diabetes. Now, on to a small conclusive comment about bariatric surgery. What is the role of bariatric surgery in diabetes?
Bariatric surgery role by is evolving with time. We know that it can be quite effective in reducing weight, and it can be quite effective in improving glycemic control. Some people would say there's also resolution of type 2 diabetes. In fact, there are a number of studies which show this, but after a number of years, actually type 2 diabetes will recur in a number of patients. But that's not so important to be fixated whether there's resolution of diabetes or not. What's important is does it improve glycemic control, and yes, it does. So bariatric surgery has a role both in reducing BMI, which we know is associated with increased mortality and morbidity, and also improving glycemic control. And in fact, the improvement in glycemic control predates the weight loss. For reasons probably is that there are the number of hormones which are released in the gut which change after bariatric surgery. So the role of bariatric surgery is evolving. We normally would reserve it for people who are morbidly obese with a BMI of more than 40, although criteria vary from one sector to another, and then those who are committed to lose weight, because what the surgeon or anyone would not want is that after bariatric surgery does have risk like any other surgery, he loses weight and then starts gaining weight again. So the patient would normally be required to lose some weight before bariatric surgery, and then if he's psychologically prepared, would go for bariatric surgery if the indication would be patients who are morbidly obese at a BMI of more than 35 or 40. A strong indication would be if there's also type 2 diabetes or sleep apnea, because loss of weight also helps in the treatment of sleep apnea.
Thank you, Profs, for the information you've conveyed with us and for your time. We'll be with you with more the Synapse videos in the coming weeks. Keep in touch, bringing content that matters to the busy medical professionals. Thank you.